Hi, everybody. Welcome to We Can't Do This Alone. My name is Erin Stitzel. I'm your host. And today we are launching a 6-part series all about how patient data supports healthcare philanthropy. So we're really excited about this series. We're thinking it's going to be about 5 or 6 episodes. And to help me with this, and someone who's going to be with us through each of these episodes, is my friend and my absolutely brilliant colleague, Debbie Ferguson. Debbie, welcome to the show.
Hey, Erin, I am so excited to be here, especially after hearing you talk about this for,
Yeah,
I don't know, 2 years, to
three,
finally, three?
3 years.
Okay.
Yeah,
Yeah. Well,
yeah.
to see you launch it and then the honor to be asked to participate is just incredible. So thank you.
Well, I have to tell everybody, Debbie is my first guest that we have had. So Debbie has stepped up as my colleague, but mostly in a friend capacity to help me learn all the ins and outs of the tech involved with doing a podcast with a guest and how to kind of structure and prepare that guest. So, sidebar, if you're ever launching a podcast, ask your friend to be your first guest, to be the guinea pig. And Debbie, you have stepped up marvelously. So, I will say when I wanted to launch this podcast, obviously, as I've talked about before, the importance, we're going to talk a lot about grateful patient fundraising here in healthcare philanthropy. Patient data is a huge part of that. It always has been. And there is no better person, honestly, in this country, in my opinion, to talk about this. Debbie is an expert. And there, again, just no better person to bring on to talk about this. And honestly, Debbie, you were one of my first people that I would ever want to bring on the show. So thanks for saying yes.
Well, I always introduce myself as, hi, I'm Debbie and I love data.
Absolutely. And that's what we're calling the series. Debbie Loves Data. So before we launch into what this series is going to be about, what today's episode is going to be about, Debbie, if you wouldn't mind taking a couple minutes or 30 seconds, just tell us a little bit about you, your background, how it came to be, how you got into healthcare, all the things, if you wouldn't mind.
Sure, of course. So, like most folks my age, I fell into fundraising and I realized pretty quickly on that I loved the front line. I loved relationships, working with donors and potential prospects. But if an organization did not have a very sound infrastructure, particularly a database, then it was very challenging to work. And so I've been in fundraising for about 2 decades, just over that. And I've seen a lot change over that time. But what I really believe is that operations deserves a seat at the table, because involving operations is not just to have support, it's to build strategy. So I like to get excited about operations. I love all things fundraising, but I love data. I love clean data.
You love clean data. We're going to talk a lot about that over the series. Clean data is important. Absolutely. Well, and I think, one of the things you just said, operations deserves a seat at the table. So, a little bit of background about how Debbie and I started working together. So, I've been with Accordant for 10 years. I was consultant number 3 at Accordant. We were 1 year old when I joined. And we, quite frankly, we did not have a data expert on our team for a couple of years. I always say myself personally, I know enough about the database to be dangerous. We can I can work my way through a database. I can log whatever we need to. I can pull out a simple report. But I always say, I've told this to so many people over the years, when Debbie joined Accordant, I don't know how we managed without her. So, and how long have you been with Accordant, Debbie? I can't quite remember. I feel like forever, because I don't honestly remember working at Accordant without you. But how long has it been?
Just over 3 years.
Seriously? No,
Hmm.
seriously. I was going to say 5, but then I was going to let
No.
you answer because I wasn't fully sure. That's
Yep.
it.
Just over 3 years. And I love it. I love everything about healthcare philanthropy and the impact that we're able to make, because saving lives is uh, there's no higher calling than saving lives. And when you're raising money for healthcare, you're directly impacting, not just individuals, but communities, families. So very excited work.
Well, and Debbie, you joined Accordant before you were working with a large healthcare system, kind of like I was before I joined Accordant. And so I didn't know if you wanted to dive into that at all. How long you were working in the front line.
Sure. Yeah. So, my trajectory in fundraising is not linear, like most folks. And I first of all, I live in Florida. We have a lot of healthcare systems here. We have a lot of higher education institutions within a really concentrated area. So I worked between healthcare and higher education and found myself working in annual giving and then prospect research and management. I served in North Carolina as a major gift officer and executive director of two rural healthcare foundations that merged under a Department of Philanthropy for a healthcare system. And during the progression of my career, I was able to build and implement two grateful patient programs from scratch. And that kind of brings us to where we are today, because it takes time, and it really helps when you have good relationships across the board. And I think we're going to talk about that a little bit today.
We are. Well, and I'm glad that you brought up your background a little bit because I think it highlights one of, in my opinion, what makes you so incredible. It's your superpower, quite frankly, is that you're not just a data person. You said you're a major gift. You have been a major gift officer. You are a relationship builder. You have closed gifts. You've been a fundraising leader, but you're also a data person. And a lot of times it can be easy to just put yourself in one or two box. You either understand the database or you don't. I would say I'm in the don't category. Again, I know enough to be dangerous, but I don't really understand the why or the how. Just tell me what to do and I will do it. And I'm a great relationship builder. I'm a frontline fundraiser. You've been both. And in my opinion, it's just been such an asset to us and a resource because to understand the data piece and understand the infrastructure and how to build it and how to get into a database and do all the things that you need, but also be able to build those relationships. It's your superpower. It's incredible. So
Well, I mean, I do feel a little bit like a unicorn in that, but I really identify with being a bridge builder and a collaborator. And in this work, there are so many stakeholders,
yeah,
and they all deserve a seat at the table because there's so much at stake in building authentic relationships but managing those relationships. And
yeah,
if we don't have a paper trail or data points that mark the progression of that relationship, then we're stuck with institutional knowledge. And we all know that fundraisers sometimes stay 2-3 years, and then when
if
they
that.
leave, they bring that relational collateral with them if it's not properly stored and managed. And
Absolutely. It's all up
yeah,
here. And if they take it with them and it's not in the database, you're not in a good place. So
didn't happen, right? If it's not in the database, it didn't happen.
I know a lot of frontline fundraisers hate that line, but it's so true. Yeah. If it's not in the database, it didn't happen. Yep. Everyone has heard that, I'm sure, myself included. So, Well, and so too, I'll share. I mean, Debbie and I, we work together almost daily at Accordant because, as Debbie mentioned, she's got extensive experience at implementing grateful patient programs, as do I. That's what I do at Accordant. And so we work together with almost every organization that we work with around the country. Obviously, I'm helping build and find clinician partners, helping gift officers succeed in building ally relationships, training doctors and nurses how to work with the foundation. On the flip side, Debbie is working behind the scenes, ensuring we have that infrastructure in place, ensuring that the organizations have access to data. And how are you screening that data? How are we using it? How are we tracking that data in the database? What are those best practices? How can we really maximize those opportunities? And it's funny because every single thing I just mentioned is going to be an episode in this series. And so this is episode 1. We're planning to do a 6-part series to talk about all of those things. First, today being our introductory episode, but today we're going to talk about what patient data we're allowed to use for fundraising, and more importantly, how to access it. Future episodes are going to include the why and the how of patient data. We've got that data. How do we use it? Why do we want to use it? We're going to talk about, okay, we've got the data. Now what? What do we do with it? We're going to have a whole episode around AI and patient data. There's a ton of tools out there that are really helpful when it comes to using our patient data. We're going to dedicate a whole episode to AI. We're also going to dedicate a whole episode to how to track how we're using patient data ethically and compliant in our database. We're going to bring a special guest on for that episode to help us with that. And then lastly, we'll wrap it up with the best practices. How do we really maximize this patient data? And so we're really excited about this series. Actually, a little side note, we tried to already record an episode and talk about all of these things in one episode, and it was too long. So we took a step back. Now we're re-recording and we're doing this 6-part series. And so let's get started talking about the topic at hand today, which we've got to go back to the beginning. When we think about healthcare philanthropy, using patient data to support philanthropy, what pieces of patient data are we legally allowed access to? So let's spend just a couple of minutes talking about that. Debbie, as our resident expert, what are those pieces of data that we're allowed? And 2, I will preface it by saying, so when we say, you will hear us say HIPAA compliant PHI, that means patient information we are legally allowed access to through HIPAA. PHI is an acronym for protected health information. So when you hear us say that, that's what we mean. So I'm going to kick it over to Debbie. Let's talk about what pieces of patient information are we legally allowed access to for fundraising purposes.
So the data that we are allowed to have access to includes the contact information of the patient and their date of birth, their gender. We also are allowed to have access to the guarantor on the account, and the actual health information that we can have access to includes the area of service, the physicians, the dates of service, and then the outcome. So health information, health insurance information is allowed to, but generally that is not needed as much. Some folks use that. We can talk more about that later. So just coming down from the top, it's really, who came to the hospital, when did they come, what are their dates of birth, who did they see, and what department of service did they receive care at?
Well, and I think, it's really important. So, as both of us have been in healthcare philanthropy for 20 plus years, and it's really important to share. So, HIPAA was enacted in 1996, this patient privacy law, and HIPAA has always allowed fundraisers to have access to patient data. But I will share, prior to 2013, fundraisers, we were a little bit restricted. So we were only allowed access to, as Debbie mentioned, our contact information, the patient demographic information, name, date of birth, address, phone number, etc. We were allowed access to dates of service and insurance type only. And so from a fundraising standpoint, we could do some with that. We could send mailings and visit folks in the hospital and so forth. But all of that changed in 2013 through the HITECH Act, which relaxed the laws a little bit. Through that law, it allowed fundraisers those additional pieces of information that Debbie talked about. Like you had said, the physician name, the area of service, treatment location, and their outcome. And so this really opened up a huge opportunity for fundraisers to be more strategic in our work, as well as being able to just finer, what's the word I'm looking for? To be able to dig, there's thousands of patients walking through our door, being able to fine tune that and use those filters to really dig in and whittle that down to a more manageable number has been huge. So we're going to spend a lot of time in future episodes talking about exactly why this is important and what to do with this patient information. And so, anything else to add, Debbie, around what we're allowed to access before we jump into how to get access to this information? Do we miss
Sure, yeah. I
anything?
think we should pause at the area of service because that is something that sometimes is difficult to pull from a database like Epic or Cerner. It
Sure.
is a little bit tricky in the sense that it is not a diagnosis and it is not a treatment. And so you think about the DRGs in the database, all the medical billing codes. We can't have those and we don't need those. I don't need to know exactly what the diagnosis is or how the patient was treated. But it is very helpful, obviously, to know what department they received care at.
Absolutely.
Yeah. And then when it comes to physician, we're not limited to just the physician that they saw at the hospital if they are
Well, because a
inpatient.
patient's going to have many physicians, right?
Yeah, that's right. And so not only are we allowed to have that, we can talk about later, it's strategic to have more than one physician.
Absolutely.
And a lot of times you may not really need that hospitalist they saw. You would benefit more from having their primary care physician or their referring physician.
Absolutely. Or their specialist. So,
Right. Exactly. Yeah.
well, we always say to organizations seeking data, physician name, well, you're going to get at least 3. You're going to get, so typically the admitting physician, if they're in the hospital, is going to be a hospitalist. The patient's usually probably doesn't have a long-standing relationship with that physician. But again, they're going to have a relationship with their primary care physician. So we want that. We also want their specialist, which is their discharge physician or whomever they're seeing. That's going to help point us in the direction of, okay, this is an oncology patient. This is a cardiovascular patient. And those are the kinds of things that we'll get into later in the series about why that's important. But, for all intents and purposes today, when we say physician, you're going to want all the physicians to pull those. Now we're going to dive into how to get access to patient information. And, you might think, okay, we've been legally allowed access to this information since 1996. So that was a long time ago. Everybody has access to patient information for fundraising purposes, right? And I mean, obviously, Debbie's smiling. I'm smiling because we work all over the country, and the answer is no. Not everybody has access to this information, and it can be tricky to get. It can take some time. So we're going to talk about that. We're going to dive into that. So those of you out there who are listening who don't have access to patient information, those fundraisers, you're not alone. It's actually a lot more common than you would think, which is why we're dedicating basically a whole episode to this. So, Debbie, from your point of view, where do you start when you want to get access to patient information for fundraising purposes? What do we do first? What would you do first?
It begins with assessment in the sense you need to understand the relationships between your privacy officer, your patient experience team, your chief technology officer, your CISO. It starts with relationships and understanding who on the healthcare system's privacy team and IT team has experience working at an organization that has been involved in a grateful patient program. You sort of need to take the temperature before you even begin and understand how the CEO feels about grateful patient fundraising. And then once you understand that, you have established a culture that either needs to completely change with the help of your
Sure.
chief philanthropy officer, or a culture that just needs to grow a little bit toward and just warm up a little bit to the idea of fundraising for patients and patient family.
Well, I'm so glad you said take the temperature. It reminds me of, well, I mean, every institution has a culture, right? Some cultures are more conservative than others. And I can remember even working with an organization in Florida. Gosh, this was 6 years ago, where they were struggling to get the buy in they needed from their leaders to be able to access patient information. Well, their chief information officer left. They hired a new chief information officer who had been part of an organization prior who had a really thriving grateful patient program. And this chief information officer was like, absolutely, we've done this before. It's fine. I can help. And it changed the game almost overnight. And this organization was then able to have access to that. That's not,
I'm working with an organization right now that is completely like that, where the former CIO was not interested. They've retired, and the new um, sheriff in town has so much experience that they can't wait to get started. And when you go beyond that assessment and taking the temperature, then you start with the education. And
yep.
it adult learners have a lot of different ways that they like to take in information. And our fearless leader at Accordant, Betsy Shape Taylor, has written so many articles about patient
Yep.
fundraising. Erin has written so many articles. There's podcasts out there, so many resources that can be leveraged to share with your internal team at the C-suite why this is important, how to just get started is really understanding where you're at now.
Well, and I think, this brings up two things in my mind. So, from a philosophical standpoint, I think the first hurdle is just getting beyond that mindset of it, maybe seeing it in a bad light. So I'll share a story. So before I joined Accordant, I was with a big Catholic healthcare system for 12 years, and I started my first Grateful Patient program. This was in 2008. So it was pretty new at the time. Not a lot of institutions around the country were doing big Grateful Patient strategies. And I was young, and I'll never forget. Anybody that knows me has probably heard this story. But I had a nurse manager accuse me of wanting to walk into a patient's room and step on their oxygen line to get them to write me a check. Literally, the mindset was, how can you raise money from our poor, sick patients? Debbie, have you ever encountered anything like that?
Oh, sure. Yeah, absolutely. And
Yeah.
in those situations, you often need some education. You need a cheerleader, and sometimes you even need an early win, and that can move the needle for folks. But 100% had clinicians turn us away by accusing us to have people open their checkbook at
Yeah.
the bedside.
Well, I will say, so after we launched our program, that same nurse manager, she did apologize. About 6 months later, said, "Oh, I shouldn't have said that. I get it, what you're trying to do." But it was absolutely something very memorable for me, as you can imagine. And, I think if you're in that situation where you have apprehension at the top, or if it's not settling well, or you have questions about why would we want to raise money from our patients? Again, like you said, Debbie, there are so many articles out there. I mean, gosh, we could spend a whole episode talking about, but patients want to give. They want to connect to the foundation. They want to express gratitude for the care that they've received. We're not asking anything. And so I think being able to share examples, look at your past too in your database. I promise you, patients have been giving for years. And it wasn't because you approached them. If you're not doing any grateful patient work, if you're not being proactive, those patients had to find you. And they had to connect with you themselves. And so I would absolutely share those examples with your leadership team. I'm sure you have a ton of examples, small gifts, big gifts, it doesn't matter, where a patient just wanted to express gratitude.
Yep. Well, and I know that physicians inherently know this because during the holidays they receive gifts during
Yep.
and and so there are plenty of examples of people wanting to say thank you and not having a way to do it. So just bringing that to whoever's attention is needed, um, is certainly a good place to start.
Well, I love that you just brought that up because, too, absolutely. Every single physician in your healthcare system is hearing gratitude every day. And like you said, Debbie, patients are bringing in food, donuts. I'm in Ohio. It's all about the donuts here. Our caregivers get a lot of pizza, donuts, Chick-fil-A. I'll share a story quickly. So one of the organizations I was working with in Southeast Ohio and West Virginia, their head of family medicine, at the time she was just in private practice, told me that she had a patient gift her a pregnant cow because she knew her daughters loved animals. And I will never forget that. That's the most incredible example I've ever heard. I love it. She said they'd meet for 3 years. Now, many families cannot accept a cow. Obviously, this physician was in a position where like they could care for a cow at home. But this is happening every day. So thank you, Debbie, for bringing that up. Just go talk to your doctors, see how they're seeing gratitude, what their patients are doing. Because if they're going to give someone a cow, those people are in a position to make a gift. And, we don't want to tell somebody how to express gratitude. If somebody wants to bring in a cow or bring in donuts, that is perfectly fine. But gosh, if they would have known you had a foundation and would have known, a lot of times it starts with the food. They don't even know you had a foundation. And then they want to also make a monetary gift, right? So we're missing opportunities, right, Debbie?
Sure, yeah. So kind of back to the question, how do we get started? We
Yep.
take the temperature and then we find a champion. And inherently, anyone who has been told thank you can be a champion. My husband is not particularly philanthropic, even though he's been married to me for 14 years. And he's a school teacher, though. And every day he receives little notes from his students and from parents telling him how much they appreciate the impact he has made in their life. And physicians get that too. And so anyone who can give you a little bit of support to get the ball rolling is the next person to talk to. But I'd love to talk a little bit about building that relationship with the CISO and connecting the bridge between privacy, patient experience, and the foundation. Is
Okay,
that a
I'm going
good
to ask
place
you
to
a really
go?
stupid question. What is CISO? What is what does that stand
Chief
for?
Chief Information Security Officer.
Got it. Okay. See, you know what? 20 years in healthcare, and you learn something new every day. Chief Information Security Officer. Awesome. Keep going, Debbie.
Yeah.
Keep going.
Yeah. So, well, I think that role is a little bit newer, and it's come out
Sure.
ever since cybersecurity became a college degree. And so they tend to be my point of contact these days. I mean, the
Sure.
CIO, obviously, and the CEO, but the CISO is the one that's really plugged into the organization security posture. And they tend to be the gatekeeper of the patient data. I think from there, one of the best ways really is to introduce a vendor that can be a third party between your healthcare system, the database that your healthcare system is using, so Cerner or Epic, and screening services. Certainly, you can send data directly from the healthcare system to the foundation, but until that data is screened for some kind of likeliness to give capacity, um, it really can be a flood, which is a whole episode in itself too.
It is.
But it tends to be a good idea to put a vendor in that gap, because a lot of times a vendor will be SOC 2 and just have a very strong security posture as well. And they, on the information side for your system, may have more confidence in that than sending it straight to the foundation. And that's not to say I don't know foundation members that have access directly into Cerner. I have worked as a consultant for healthcare systems that want to give me access to Cerner. So it can be all across the spectrum.
That makes my heart start pounding. But yes, I'm sure that's happened. Woo, that gives me heart
Me too.
palpitations. But
Yeah.
yeah,
Nope. They're like, oh, I'll give you a login. You know, here's Slicer Dicer. We can pull the report for you, and then you can just go in and see it whenever you want. Um, you know, it volume matters, and so if you have a way to just connect between the patient data and yourself through a third party is really helpful too.
well, and I'm glad you brought that up because, too, it begs another point around that third party vendor has a lot of experience doing this. So they have probably helped many, many institutions like yours get access to this data. And so they're going to bring those examples and experiences to them to show your leadership. This is a good thing. This is safe. This is legal. This is ethical. We do it in a very professional, responsible way. So you're in good hands.
Yeah. I mean, the other option really is, the workflow can be directly to the foundation rather than that third party. But if the data is coming directly to you, then you have to figure out what to do with it. And there are, you certainly can bounce it against your own database. You can send it to a vendor yourself. You can segment it yourself and use all of it. But earlier, Erin, you're talking about how the ability to target increased once we had access to area of service and physician names, and certainly, we don't have to be analysts. I love data, but I would rather have data that has been screened at least a little bit.
Absolutely.
Before I use it. I do want to backtrack real quick about the data that we are allowed to have and how there is data we're not allowed to have.
Sure.
And I don't know if we covered that, but that is something that a third party vendor can help you with as well, because there's folks that we don't need to have in our patient pool. And then there's folks that may be less desirable to have in our patient pool. Some folks might be a hospice organization, and so they do want patients who have been discharged to hospice. Other
Sure.
organizations may not. And so, patients that had a negative outcome, we already talked about outcome um, data point, but folks that may have been admitted for behavioral health concerns or for substance use disorder are not permitted in the general screening. Yeah.
Well, I'm glad you brought that up, and I think point being, obviously, there's a lot of patient data out there. Even sometimes we don't even want all of it that we're allowed access to. And, I think we're going to spend a lot of time talking about that in our next episode. But I think, based on what Debbie and I have been talking about when it comes to getting access to patient data, what we're telling you is you need to have a screening service as well. And again, we're going to talk all about tools in later episodes about what to do to get that screen. But yeah, when we say, you'll hear Debbie and I say a lot of times the flood of patient data. We actually wrote a white paper about that a few months ago. A lot of times it does no good to have thousands and thousands of patient records if you don't know where to start or how to screen them. And two, another reason why it's important to talk about getting access. So we've worked in countless organizations where, like, say 10 years ago, they had access to patient data and they were getting all these screenings every single day
Mm-hmm.
with like one person on their ops team who had no idea how to manage it, and it became too arduous. And so they threw in the towel and said, nope, we're done. Like, I can't deal with all this data. Even earlier, before we started recording this show, I was on with a chief development officer here in Ohio, who largest healthcare system in Ohio. He said when he started there a few years ago, they didn't have access to data because they had thrown in the towel.
Mm-hmm.
And it took him 11 months to get access to that data. So again, a lot of you might be in a situation where you might be in that same boat. So,
Mm-hmm.
which too, I think also brings us to something else we wanted to talk about: timeline. Debbie, in your experience, gosh, again, we're starting with our chief information security officer, our privacy officer, finding that champion. How long does this take?
Well, it can take a long time. I
Yeah.
think I've heard you say it's a marathon, not a sprint.
Mm-hmm.
And even in a situation where they have had access in the past, but need to kind of restart the pipeline, that can take it could take a minute. It could take longer than a year, particularly if your organization was on one CRM or one EMR and now they're on another. Well, your report will need to be rewritten that goes to your vendor or goes to the foundation. And that is one of those relationships. Once you get the green light, you will want to have a relationship with someone who is more technical on the IT side, who will be
Sure.
writing your report and editing your report to make sure that it comes out like you like. And in that, I worked at one organization where the old report was admit data. In the new program we were launching, we wanted discharge data.
Sure.
And so to flip that around took a very long time. You wouldn't think it would,
Sure.
but it did.
It always
And
takes longer than you think.
right, yeah.
Sorry for the bad
And
news, everybody. It always takes longer than you think. Oh,
there's a lot to do in the meantime. And I mean, Erin and I will tell you all about that. There's plenty to do between when you can get that clean, consistent data flowing. But it may take a minute.
what's the longest process you've ever helped a client, or what's the most significant thing you've ever done to help a client or an organization gain access to this data?
Almost 2 years is the longest. And I know you have some good stories about what what you've had to kind of hurdles you've had to jump to get the data. But
Yeah.
I would say, I had to write an SBAR on what the situation had been when they had access before
Sure.
and what my recommendations were. And it involved building a committee of stakeholders. And that was a challenging, arduous task to bring people together, to share ideas, to have buy-in. When you include not just privacy and patient experience, you also include risk management. They have a piece of the program because, like we were talking about earlier, there's folks you don't want to include, and risk management knows who they are too. So what's your story? I can't remember, but I know you
Well,
have a
I
good
didn't
one.
know. I mean, building an actual committee. I know in healthcare we love our committees. In philanthropy, we love our committees. I didn't know you did that, Debbie. That's unique. That is good. Yeah, my example was this was a huge, like world class healthcare system we were working with. Someone that you would never think would not have access to patient data. And they wanted examples literally from around the country. They wanted to know exactly who was accessing this data and who wasn't. And so we actually, Betsy Taylor and I, our CEO, set out, we did a national survey where we were literally we called all the largest healthcare systems in the country, like Google it, you can find your top 10. We know, so we're calling the top 10 healthcare systems in the country. We also had to call every single healthcare system in that city. So this was a big city, and we had to actually put together a report of like an analysis of who. I think we surveyed like 50 or 60 organizations across the country saying, 87%, I'm totally making that up, but 87% of those we surveyed do have access to this data. And I think at the time too, in that particular community, I'm pretty sure every single other healthcare system in that city had access to patient data. And so, obviously, like, we didn't mind doing that. We're going to do whatever it takes to help our clients. And it was actually kind of fun too. But I would say, that one always sticks out to me as, but, of course, like, if you're a leader of a healthcare system and you're having second thoughts about doing this, knowing that every other institution in your city is already doing this is going to help you feel better. So, yeah, that was my story. So, okay. Well, okay. So, I think to wrap this up, we've talked about what data we're using, we've talked about how to get that data. Next episode in this series, we are going to talk about why we need patient data. We've dabbled on that a little bit, obviously, to be more strategic, to help us pinpoint different things. We're also going to describe all the many ways that you can use it. And so, again, we're talking about why we need this data. Why? How do we use it? So, we're going to spend a whole episode on that. But to wrap this up, Debbie, I will ask you first and foremost, anything else you might want to add for today? Anything we missed?
Sure. I love the expression that philanthropy rides on the rails of relationships. And you'll hear
Yeah.
me say that again and again. And I love data. I love being curious. I love asking questions about the data. And we'll talk more about that later. But we have to have relationships with our colleagues at our healthcare system in order to make this work. It is a marathon, and you got to be in it for the long haul because there'll be barriers, there'll be obstacles, but you stick with it. On the other side, you're gonna see gratitude. You're gonna see those 8-figure gifts, and I can't wait to talk more about those.
Well, and I mean, in my healthcare system before I joined Accordant, when we did this, I never knew that I needed to be best friends with a privacy officer. I had no idea the privacy officer existed. Didn't
Yeah,
know who that was. And we were best friends by the time that
yeah,
ended. And I'm sure you have similar examples as well.
I do.
Building
Yeah, I do.
relationships with those you didn't even know you needed to. So,
Yeah.
all right. Well, I'm going to ask it, Debbie. This podcast is called We Can't Do This Alone, and we cannot do healthcare philanthropy without our data. So, Debbie, what is your one piece of advice to philanthropy leaders, philanthropy officers out there who don't have access to patient data but want to? What's your one piece of advice for them?
It begins with taking that temperature and having some education, and asking the right questions. So just jump in. There's no time like today.
Love it. Well, and it's going to take you some time. So you might as well start today, right? Unfortunately, we're the bearer of bad news is on that. It's going to take some time. So, okay. Well, Debbie, I cannot thank you enough for joining me today. We're so excited about this series. Again, this was episode 1 of what we're thinking at this point, a 6-part series all about patient data, supporting healthcare philanthropy. Our next episode in this series, again, we're going to be talking about how and why to use patient data and go through all the ways that we can use this data to support our work. In the meantime, I want to thank everybody for joining us today. This is We Can't Do This Alone. I'm Erin Stitzel, your host. Thank you so much for joining us, and we will see you next time.
Bye.